So in the interest of time and as a special gift to those who have arrived on time, Dr. Chumbar inclusive, we will start. Welcome everybody to this grand round for the Department of Endocrinology, which is going to be related to the sort of the concept of growth hormone and its physiology and pathology. I will not take any more time and hand you over to Dr. Kankawat, who will be coordinating today's grand.
Thank you, sir. So we are starting this CGR. Height matters. Yes, height matters for those short. Height matters, and those for tall, height also matters for them. So this is our clinical journey of last so many years. We started our growth clinic in 2008, and since then we are regularly working in our clinic. And we have a large team who is presenting that. Dr. Manaswani and Dr. Iram are assistant professor with us. Dr. Jyotsna would be joining soon as she was in OPD. Then we have Dr. Rakesh, Dr. Akanksha, Dr. Ayushi, Nupur, and Dr. Sachin, who would be presenting different parts of our journey of growth. So I request Dr. Manaswani, assistant professor in Department of Endocrinology, to carry on. Dr.
Thank you, sir. So I would be laying down the basic foundation for the next 50 minutes of our clinical plan. So as we all know that 90% of an individual's final adult height is achieved before the onset of puberty, and this is mainly determined by two major growth spurt phases. First is postnatally under the influence of growth hormone and thyroxine hormone, and the second one is during the time of puberty under the influence of gonadotropins. So from birth till puberty, the average growth velocity for both males and females is known. But the question that arises when we look around is why there is so much variation in height among individuals. The answer to this is the concept of heritability of adult body height, which is higher in men as compared to women. And apart from heritability, there are other reasons such as nutritional, environmental factors, and presence or absence of disease state, which determines the final height of an individual. So in this CGR, we'll be predominantly focusing on disorders for short stature, but briefly we'll also be discussing about tall stature. Just a reminder that short stature is not always abnormal. What is abnormal is the term which is called growth failure, which is a failure of a child to achieve or maintain growth velocity, which is normal for age and maturity. So by definition, it gives us some idea about the underlying pathological cause of the disorder. So how do we define short stature? It is height STS less than -2 standard deviation or below third centile. So apart from the baseline height, the concept of growth deceleration is very important, which depends on the height velocity of an individual. So height velocity or growth velocity is best possibly measured with theory measurement, and it should never be measured less than 6 months. So by this time, most of the data of height velocity which we were using were from the Western countries, and that there was not much data available from India. With this concept, we had planned a prospective longitudinal studies from 9 public schools from all 5 regions of Delhi, and we included around 5,635 school children of age 4 to 17 years. And we plotted the normal height velocity centiles for both boys and girls. Apart from this, we also plotted the growth velocity curves for boys and girls. As you can see, it's a known fact that before the onset of puberty, there is a lag in the growth, followed by a pubertal height spurt. And since puberty is a very important phase for gaining an individual's height, and we also derived the normative data for age of onset of puberty in healthy school girls as well as school boys. And we also determined the impact of obesity and overweight on the onset of puberty. And we found that obesity and overweight causes an early onset of thelarche and menarche in girls and puberty in boys. So broadly dividing short stature, either it could be physiological causes or it could be pathological causes, which can be primary growth failure, which includes skeletal dysplasia and dysmorphic syndrome like Turner syndrome we commonly see, and secondary growth failure that causes could be systemic disease or endocrine disorders. So this slide shows the Indian data from tertiary care centers. Over the period of 10 years, we can see that there is an increase in prevalence for detection of growth hormone deficiency. The cases were initially labeled as familial or CDGB are less over the 10 years, and there is also a decrease in the prevalence of hypothyroidism over 10 years. So this is a study which was published from a center in which we studied around 432 children with short stature and found out that the endocrine causes was present in 34% of cases of short stature, and the predominant deficiency was growth seen in 20% of individuals. As far as systemic disorders, it was present in 22% of the group. And the most common systemic disorder was celiac disease, seen in 11% of individuals. So who needs evaluation for short stature? This is an important slide because this is the criteria that we use in our clinic for evaluation any child with short stature. So more than 3 standard deviation below the mean in severe short stature requires immediate evaluation. The rest of the definitions are mentioned in this slide. So the first line investigation is very important to always look for common causes first, especially the systemic illness. So these are the battery of tests which we ordered at the first visit, which includes a simple hemogram and LFT KFT. Very important, never miss thyroid hormone function test. And serum FSH for baseline for all girls. And the tissue transcriptaminase antibody to rule out celiac disease. We also need to do 3 important X-rays, which include a chest X-ray for a ruling out chronic infection, lateral view of skull to rule out phalangomas and notice any cell widening, a very important left hand X-ray for image assessment. For the second line investigation, we go up for uncommon causes like growth hormone deficiency, depending on what are the results of the first line. And third line becomes much more targeted intervention, such as MRI, pituitary, phenotype, or genetic disorder. So now on the physiological cause of short stature, we all know the first is familial with short stature. So babies are short and the child is short because the MPH is less. The very important fact is the child grows normally, all the endocrine profile is normal, and the final height is equals to the mid-parental height. So this is the graph of the patient in our clinic. So you can see height is in the same percentile of the mid-parental height. The second physiological cause is a constitutional delay in growth and puberty, which is just a normal physiological variation in growth, which occurs around second to third year of life because of delayed maturation of growth hormone pulse, more commonly seen in boys, and it's a diagnosis of exclusion. The most important reassuring thing is that the patients have normal growth velocity, and the history that the younger sibling is taller than the index case is never present in the case of CDJ. And CDGP is the area of money-making business by these pharmaceutical companies like Speedhide and Hypermax, which actually claim that their medication is working, but it's not. It's the CDGP, the normal phenomena, which causes the height spurt in these individuals. Coming on the pathological cause, the most important endocrine cause is hormone deficiency. To further discuss it, I would like to invite Professor Jyotsna Madam to carry forward the presentation.
Thank you, Dr. Manaswini. So growth hormone deficiency is not a common cause of short stature. And when present, it is usually causes severe short stature. It can be alone or it can be present with other pituitary hormone deficiency. But isolated growth hormone deficiency is more common. Next question. Okay. So, we take a history of breech deliveries or birth trauma or surgery or radiotherapy in the pituitary region. In the neonatal period, GH deficiency can present as hypoglycemia or prolonged jaundice. The genitalia is normal, but micropenis may be present. Growth is almost normal up to the end of first year. Thereafter, height lags behind, and the growth velocity is always less than 5 cm per year. GH secretion, as we know, occurs in bursts, and even night time, there is increase in the pulsatile secretion. So for a diagnosis of both growth hormone deficiency, we suspect when the bone age is delayed more than 2 years, the chronological age. And it is important to rule out systemic diseases like celiac disease, renal tubular acidosis. The patient should be euthyroid, eucortisolemic. For screening test, we have the serum IGF-1 and IGF-BP3. But there are other causes of low IGF-1 like malnutrition, liver disease, kidney disease, hypothyroidism, uncontrolled diabetes. So confirmatory tests are required and 2 confirmatory tests are done. So sex steroid priming prior to the growth hormone stimulation test use is still controversial. It may be considered in peripubertal children, and the rationale for its use is that it Priming reduces the chances of false positive tests. So for the growth hormone stimulation test, we take a basal sample and after giving the pharmacological stimulant, we collect samples at 30, 60, 90, 120, 150 minutes and done in the fasting state. And for the interpretation, if any sample is more than 10 nanogram per ml, it rules out growth hormone deficiency. If all samples are less than 10 nanogram per ml, it confirms growth hormone deficiency. If all samples are less than 5 nanogram per ml, it is severe growth hormone deficiency. And we need confirmation by 2 tests. So these are the various stimulants used. Among them, clonidine stimulation test and glucagon stimulation test is commonly used. Insulin tolerance test has the side effect of hypoglycemia, seizures, and even deaths have been reported. So less and less of it is being used. The arginine and GHRH not easily available. So why do we need 2 tests for a confirmation? That is because the specificity of the test individually is less and the coefficient of variation is wide. So over to Dr. Akanksha for the challenges in GH stimulation.
So as we have seen, growth hormone stimulation test remains the gold standard for the diagnosis of growth hormone deficiency, but it is associated with several limitations, such as the stimulus that we use is pharmacological and not physiological. There is absolute lack of normative data, especially from the South Asian countries, and the cutoff that is used to define growth hormone deficiency is completely arbitrary and has evolved over the years from a cutoff of 5 nanogram per ml in the 90s to the present cutoff of 10 nanogram per ml. So this was a study from our department where nearly 550 children with short stature were underwent testing for growth hormone deficiency. Clonidine stimulation test was performed in all children, and glucagon stimulation testing was done when clonidine stimulation test was inconclusive. So the primary outcome was to see if the number of samples that are drawn can be reduced to reduce the time taken to perform the test. However, as we can see in the table, that when the number of samples drawn were reduced, the false positivity rate of the test increased significantly for both clonidine as well as glucagon stimulation. These are some of the other limitations. As we can see, the growth hormone secretory response to both clonidine and glucagon depends on the BMI of the patient, and the secretory response is more in those who have baseline BMI of less than 1 standard deviation score. Similarly, females tend to have a higher growth hormone secretory response compared to males for both clonidine and glucagon. And regarding puberty, we can see that those who are peripubertal have a better secretory response compared to those who are prepubertal. Similarly, depending upon the etiology of growth hormone deficiency, those with isolated growth hormone deficiency have a better response compared to those with multiple pituitary hormone deficiency. So to summarize, the peak growth hormone levels achieved during growth hormone stimulation testing depend upon the type of stimulus and the nature of the assay, which can be circumvented by developing specific cutoffs for each stimulus. The role of sex steroid priming still remains controversial, but some part of it can be taken care of by using separate cutoffs for pre and peripubertal children. As we've already seen, there is significant effect of BMI and pubertal status on growth hormone secretory response, which can be taken care of by using gender and pubertal status specific cutoffs. Coming to the role of neuroimaging in growth hormone deficiency, the main objective is to look for any obvious mass lesion which may require a surgical intervention. MRI is the preferred modality. In the absence of MRI, CT can be used to look for any obvious mass lesion. So this is the normal anatomy of the pituitary gland. And the green outline highlights the optic chiasma. Eye shows the infundibulum, and the red outline shows the pituitary gland in the coronal and sagittal images. So this is a study from our department. While we working with children with growth hormone deficiency, we realized that there is lack of data regarding the normal pituitary morphology from India. So as we know, there is dynamic change in the size, shape, and signal intensity of the pituitary gland with age. So this was a retrospective study involving the departments of neuroradiology as well as radiodiagnosis, and MRIs performed during the last 3 years were included. And those with any significant hypothalamic pituitary condition, any significant lesion in the hypothalamic pituitary area were excluded from the study.
the length, height, and width of the pituitary gland was measured, and the pituitary volume was calculated. So at least 20 subjects, the participants were divided arbitrarily into 10 age and sex groups, and each group had at least 20 participants. Overall, 632 participants were screened, and finally data from 482 patients were included in the final analysis. So as we can see in this table, the length of the height of the pituitary gland increases progressively up to the age of 10 to 15 years, after which it tends to remain more or less stable. And the mean height remains the same in males and females, except in the age group of 10 to 14 years, where it is higher in females, likely because females achieve puberty at a younger age. In terms of the length and width of the pituitary gland, no significant difference was obtained between males and females across the different age groups. And this is the table which shows the cutoffs which we derived based on our study to define pituitary hypoplasia and hyperplasia, and these cutoffs are now widely used. So this was another study where 152 patients with congenital growth hormone deficiency were studied, and MRI data was available for 123 participants. Overall, any radiologic abnormality was present in nearly 70%, most common being anterior pituitary hypoplasia. The table on the right here shows that when Indian data was used to define pituitary hypoplasia, the proportion of patients having a radiological abnormality reduced. Moreover, as we can see in this table, that the likelihood of finding a radiologic abnormality is more when the growth hormone deficiency is severe, which here is defined as a peak growth hormone level of less than 3 nanogram per ml. I would now like to call upon Dr. Rakesh to discuss the role of genetics in growth hormone deficiency.
So coming to the role of genetics in the growth hormone deficiency, genotype-phenotype correlation provides more insight into disease, helps in predicting the response to GH therapy and prognosis of the disease, helps in prediction of the transmission, and neurodevelopment of the therapeutics. Fewer genetic studies has been done from our country, and some of the studies from our institute has highlighted the genetic structure of growth hormone 1 gene in the Indian population, and compilation of the genotype-phenotype has been done in the GH deficiency children in our country. So coming to the genetic studies, these are the descriptive cross-sectional studies which involve the patients, parents, other affected and unaffected siblings. The key inclusion criteria of these studies are clinically and biochemically diagnosed cases of growth hormone deficiency, and the patients who are having acquired process of growth hormone deficiency in cases with any organic lesion has been excluded for the participation in these studies. So we basically studied in patients with isolated growth hormone deficiency GH1 gene and GHRH receptor, and in patients with combined pituitary hormone deficiency, we studied POF1, F1, HSX1, and POF1 gene mutations. So coming to the isolated patients with isolated growth hormone deficiency, these are 116 patients of isolated growth hormone deficiency with 100 controls. Mean age of the participant was 11.7 years. Mean height SGS was -4.5, and 9 patients had family history of growth hormone deficiency. Consecutivity was seen in around 19.8% of the patient, and MRI details were available in 83 patients. However, the morphological alteration was found in 46.9% of the patients. Coming to the details, in patients with isolated growth hormone deficiency, 24 out of 116 patients had GH1 gene or GHRH receptor mutation with 11 variation. 60% of the patient had GHRH receptor gene mutation, and the most common mutation was found in the codon 72 of exon 3 in GHRH receptor, which was found in 12 patients, and 6.7 kilobase per GH1 gene cluster deletion was identified in 5 patients. And GH1 promoter screening revealed 21 single nucleotide polymorphism. In our cohort, 4 novel deleterious, 1 novel non-pathogenic, and 6 reported changes were identified. In patients with GH1 mutations, there was an intronic 2 deletion, micro deletion, and gene conversion event was identified in 3 patients, which was not reported previously. Coming to the GHRH receptor mutation, it was found in 12 patients, and 6 patients from the 3 unrelated families has homozygous variation at codon 72 of exon 3 in GHRH receptor. And the first insertion mutation was also reported from our cohort, and the novel exon 10 insertion mutation at position 920 was identified along with the compound heterozygous change with exon 3 nonsense mutation in the 2 affected sisters. Coming to the clinical details of the GHRH receptor mutation identified in affected individuals, among the 3 families, in family number 2 and family number 3, it was reported as a homozygous state. And in family number 1, there was a compound heterozygous mutation where there is an insertion mutation at position 920 along with the missense mutation at codon 70. Coming to the pedigree analysis of the nonsense mutation at codon 72 in exon 3 in GHRH receptor. Among the family number 3, the 15 family members were screened, and there was 6 patients had homozygous variation at GHRH receptor, and 7 had heterozygous mutation for this. Coming to the clinical details of all the 24 patients with GH1 gene and GHRH receptor analysis has been done for the isolated growth hormone deficiency. Among the patients with the GH1 gene and GH1 cluster deletion have severe short stature, along with the patient where there was a compound heterozygous mutation with insertion mutation at position 920 at GHRH receptor, and there was a nonsense mutation at codon 72 of exon 3 in GHRH receptor. There was a severe short stature was found. Coming to the characterization of the GH1 gene in patients with isolated growth hormone deficiency, in 30 clinically diagnosed patients and 30 healthy controls, the genomic DNA was isolated and the acquired gene was analyzed. Among the 20% of the cases has the consanguinity and 60% had positive family history, and 7% cases have homozygous deletion in GH1 gene, while the rest had heterozygous deletion. Sequence variation was found in the exon 1 of GH1 coding region, which was found in 20% of the patient. And GH1 regulatory and promoter region screening revealed single nucleotide polymorphism in around 50% of the patient. Coming to the patient with combined pituitary hormone deficiency, around 51 clinically diagnosed CPSD patients and 100 controls were enrolled in this study, and direct sequencing of POW1, F1, and PROP1 and HSX1 gene was done. And the molecular analysis revealed 10 patients with POW1, F1, and PROP1 mutations, accounting for PROP1 mutation accounted for 6% of the mutation in this study, and POW1, F1 was found in 14% of the patient. However, none of the patient had HSX1 gene mutation. And in this study, we reported 5 novel and 2 reported changes. And the most common mutation found was the sector splicite mutation, which was found in the POW1, F1 gene. And 5' and 3' variation was also reported in 3 patients. Coming to the prediction of disease, the family with the affected child with the combined pituitary hormone deficiency approached at 9 weeks of period of gestation, and the blood sample for the first child and the parents were collected for the genetic studies, and we advised them to come back after 12 weeks for chronic villus sampling. However, at 12 weeks of follow-up, the pre-procedure ultrasound showed no fetal cardiac activity, so MTB was carried out and the fetal tissue samples were collected, and it was processed after taking due consent. And what we found that the affected child has the homozygous splicite mutation, where there was a G to A transition at position 605. However, the parents and the fetus has heterozygous variation in this mutation. Coming to the mutation in the fetal tissue, the fetal DNA showed heterozygous splicite mutation at the POW1, F1 gene, and however, the homozygous insertion mutation was also found, which at the position 128, which resulted in the production of the termination codon at position 110, resulting in the truncated PROP1 protein. This mutation was absent in the index case as well as parent, and none of these 2 mutations was found in any of the healthy control. So now I invite Khadgawa sir to tell us regarding the growth bone mineral density in patients with growth hormone deficiency.
Thank you, Rakesh. When we were started this growth hormone, at that time there was concept that growth hormone deficiency was the risk factor for future fractures or future risk of osteoporosis. But after going through all these details, we didn't find that a single patient reported with pathological fracture. So we thought it could be effect of that less size of the bone, because their height is less. So it may be possible that the size of bone is there, and without correcting, if you measure BMD and compared with the normal age and sex match control, so there may be difference because of that. So we started work on that, and subsequently in 2010-11 we published this paper in Osteoporosis International. So what we did was 30 pre-pivotal children we have taken with growth hormone deficiency, and at the same time we have taken 75 healthy control, age and sex matched, and then we measured BMD in both of them, and we found that when we corrected BMD using complex Molgard approach, where first you correct for their height, second you correct for their BMD, and finally you correct for the bone volume. By using all these 3 approach by Molgard approach, we compared and we found that there was hardly any difference. If we use uncorrected, there is a huge difference, and if we correct using the size, and this was the first time we gave concept that growth hormone deficiency is not a risk factor for future osteoporosis. And subsequently, this has been also reported from the different cohorts that growth hormone deficiency bones are not big. Bones are small, but if we correct with the size, their density is normal. And this paper was published in Osteoporosis International. And during 2012, AIIMS first time started the AIIMS Excellence Award when Dr. Deka was the dean. And this paper received the third AIIMS Excellence Award, and we received the prize from Nobel laureate. So now coming to growth hormone therapy, we have discussed diagnosis of growth hormone therapy, growth hormone stimulation test. We have done genetics, and coming to, so how do we treat? Growth hormone is available, and growth hormone is used not only for growth hormone deficiency, but for other conditions as well. Chronic renal insufficiency, Turner syndrome, Prader-Willi syndrome, SGA, ISS, Noonan. Every 2-3 years, there is a new condition is approved for the use of growth hormone. However, the childhood growth hormone deficiency was the first condition, and the dosage used was 0.18 to 0.24 milligram per kg per week, and 1 milligram contains 3 units. And when we deliver growth hormone, we count in units. Since it's a polypeptide, cannot be given orally. So injection of growth hormone is exactly similar to how we give insulin subcutaneous over abdomen or over thigh. Since the maximum growth hormone secretion occurs in the night between 8 to 10 p.m., to mimic that physiological rise in growth hormone, we advise them to take growth hormone injection between 8 to 10 p.m. abdomen or thigh. Most of the precautions we give is similar to what we tell about at the time of insulin injection. So there are not many pharmaceutical companies marketing growth hormone. So 4 or 5 pharma companies are there. It's available with pen or without pen also. Cost varies from 180 to 250 Indian rupees per unit. So if a child is taking 3 unit or 4 unit, this comes to around 1,000 rupees per day. If employer is paying for that, or if they are EHS or CGHS, absolutely no concern, they will get. But if patient is paying from the pocket, so for average class family, it's really become difficult how they procure growth hormone and how they continue with growth hormone. Nowadays, recently from last 1 year, the once a week long acting preparation is also available in our country. So how do we, just a brief impression, how we calculate the dose of growth hormone? So this is 0.18 to 0.35 we previously used, but nowadays this is limited to 0.24. We start with the lowest possible dose, and progressively seeing their growth velocity and response to increase in height, we increase the dose. So this is how we calculate. 0.2 milligram is dose, body weight multiplied by 3, because 1 milligram contains 3 units. So this is 12 units per week divided by 7. So 1.7 unit of growth hormone per day. If child is obese, requires higher dose, or if child is entering puberty, in that case, because of insulin resistance, they may require higher dose during that period. So cost of growth hormone is really very small. Previously, our 70 to 80% who are coming to our OPD, they were not able to afford growth hormone, because if you see the per year cost of a 20 kg child is around 1,50,000 rupees. And this growth hormone continues for 3 years or 4 years. It's really become a middle class family to purchase growth hormone. So only 15-20% patients were able to take growth hormone. We tried our best. But most of the family were not able to purchase. Some support comes from the National PM Relief Fund, Rashtriya Arogya Nidhi, Ayushman Bharat. They provide 50,000 rupees one-time reimbursement, and which is sufficient again for 2 to 3 months. So by this time we started searching from where we can get this growth hormone. So 3 years back, we thought that could be because of CSR help, we can take that. And we made a protocol and submitted to many agencies, and finally we roped in JB Chemicals, a Mumbai-based company. They provided a large CSR grant of 1.25 crore per year, and with that we have started providing growth hormone free to all of our children who are coming to our OPD. And nowadays it has also been covered in rare diseases portal of the Government of India, but again getting growth hormone from there, it takes a lot of time. So then we made this program, Let's Grow Together. Under this program, we are getting CSR grant not only from JB Chemicals, but we are getting from the other companies. These are the all children who got support from that. When we started providing free growth hormone, we thought that we will be able to provide growth hormone to all. Just seeing that AIIMS is providing growth hormone, we started getting patient not only from our country, from the distant part of our country, we are getting from the northeast, we are getting from the Bangalore south, we are getting all these patients, but we are getting a lot of patients from Nepal and Bhutan as well, and we ran out of money. So 1.25, we thought initially that we will be able to survive for 1 year. So by the end of January, our 1.25 finished. So all these patients were, the total CSR fund was finished. So again, 2 months patients were without growth hormone deficiency. Then we started putting restriction that we will not give after 2 years. So now we are following this rule in our clinic that we will provide growth hormone to everybody who is coming to our clinic, growth hormone deficiency. We will provide them free growth hormone for 2 years. And after 2 years, family have to make some efforts. They have to pull in different sources. They have to get support from the different government agencies. And by that, they can continue 3 years and 4 years. Now we are trying hard with the government of India whether growth hormone can provide to all patients. Still, we are exchanging letters with them. Success is not seen yet. So once we start growth hormone, once we start from our clinic, we call them after a month. So the purpose of this visit is to look for if they are having side effect, and most important, headache, edema, feta side effect at first visit, and we check thyroid function test. So it may be possible that when we are investigating, patient is only having isolated growth hormone deficiency because they are not growing. So whatever thyroid growth hormone is secreting, which may be sufficient at that time. But once we start growth hormone, they start secreting, they will require higher amount of growth hormone. So at this point of time, we find that their T4 goes down. So the purpose of first month visit is to look whether they have developed hypothyroidism or not. And then we subsequently call them every 3 monthly. And the main purpose is to look for their height and weight and to find out what's their growth velocity, they are growing adequately or not. And every year we call them and do complete workup to find out what's change in their bone age. It may be possible that with growth hormone, there is fast progression of bone age. In that case, we may lower down. We check IGF-1 level. And primarily, we use IGF-1 level only for one purpose, is to find out whether IGF-1 levels are not more than 50th centile. We do not use IGF-1 level to check the growth hormone dose, but we use IGF-1 level. If it goes more than 50th centile, then we decrease the dose of growth hormone. Now, how long we should continue growth hormone? In most of the cases, growth hormone deficiency is there, and we know that it will not regenerate. So ideally, treatment should continue lifelong. If funds are provided, treatment should be given. But in most of the patients, once the epiphysis is fused, we do not give them growth hormone. Although growth hormone not only have height effect on the height, but also have effect on metabolic parameters, on bone mineral density, muscle strength, body composition. But we do not provide them growth hormone after that. But if family is able to afford, we continue. The usual protocol at the time of transition is once they have completed their longitudinal growth, the epiphysis is fused, we stop growth hormone for 3 months. We recheck growth hormone deficiency, and then we continue in the peripubertal and adult age. So improvement in linear growth is almost the sole indication. The reason is because we are not able to afford provide them growth hormone for longer. If possibility is there, like few EHS patients are there, they are getting. So we continue in peri-transition period also. So this is just to show you few graphs of our patient. You can see this patient started growth hormone here. The height should have been there somewhere here, but so severe short stature. And when we gave growth hormone, there was almost vertical increase in the height, so much so that this boy has reached to his mid-parental height. This is success of growth hormone deficiency. If we are properly diagnosing and if we are starting growth hormone with the adequate doses, there is a almost vertical increase in the growth. So this is 7 to 8 results of 7 to 8 years of growth hormone. In this case, this young girl was diagnosed at the age of 8 years, and when we gave growth hormone till 16 or 17 years of age, you can see that she has reached to her mid-parental height. And the difference between this closed triangle represents the bone age. So there was a huge difference between bone age and chronological age and bone age. And this is the key of success of increase in the height with the growth hormone. If the distance between chronological age and bone age is more, they are more likely to get higher response. And you can see they are reaching towards MPH, which is the really very difficult dream from them, somebody who is maybe 5 or 6 standard deviation below the mean. And in this case, where we have again started around 8 years, you can see that there is again phenomenal increase in their growth. This is their initial height, and this is when we gave growth hormone. This few of our patients plotted on growth hormone chart. These patients, when growth hormone received, they all reached to their normal centiles. Not normal centiles because we have not plotted MPH, but at least for general population, they have reached in their general centiles. So response to growth hormone, as a general rule, response to growth hormone is assessed following minimum 12 months, but sometimes we also assess at the end of 6 months of growth hormone therapy, but in any case not less than 6 months, because to increase in growth velocity takes some time. So definition of poor growth response is if there is increase in height SDH is less than 0.5 or increase in height velocity less than 3 centimeter per year, or increase in height velocity SDS is less than 1 standard deviation compared to the normal children. These are the various cutoffs we use to define that those who are not having adequate response to growth hormone, and if they are not having adequate response, then we have our set of investigation we need to do. First, to check whether our diagnosis was on firm ground or not. They are taking drugs regularly or not. If compliance is not regular, the response will not be good. If there is onset of systemic illness, it may be possible that when we were diagnosing these children, they were not growth hormone deficient, but subsequently they might have developed growth hormone deficiency. So, is there any deficiency of growth hormone? Celiac disease, which was not diagnosed initially, may manifest at this stage. They may have a simple low hemoglobin, which could be affecting their growth velocity. So, if they are falling within this category, we investigate them in detail. So, to discuss further, one of our study where we have assessed growth hormone children, I would invite Dr. Ayushi to go through details of this study.
Thank you, sir. So this was a study done in our department to assess the long-term response to recombinant human growth hormone therapy in growth hormone deficient population over 7 years. We can see that the response to recombinant growth hormone was drastic in the first year of treatment as compared to other years, and a total of 99 children were included. There were 61 with isolated growth hormone deficiency and 38 with multiple pituitary hormone deficiency. We also the comparison of various Indian studies which evaluated the response to growth hormone compared to our study. We can see in this table. Our study total had 99 subjects, and the sample size was lesser in the other studies. We followed up the patients for a total of 7 years. The duration of follow-up was also lesser as compared to the other studies. And the first year velocity was similar and competitive with other studies. Now to see the correlation of treatment response with baseline parameters, we can see that the younger age at recombinant human growth hormone initiation
the lower height STS at baseline, the lower serum IGF-1 at baseline, the more delay in the bone age at baseline, and the lower peak serum growth hormone on clonidine stimulation test. These people respond better to prominent growth hormone. We also evaluated the effects of growth hormone replacement in patients with isolated growth hormone deficiency versus with multiple pituitary hormone deficiency, and the change in height SDS was not statistically significant between the two groups. When we compared the evaluation in prepubertal versus peripubertal, the change in height SDS was comparable in two groups. And another study, we evaluated the efficacy and safety of once weekly growth hormone for 2 years in prepubertal children with growth hormone deficiency as compared to daily growth hormone, where we saw that the height velocity was comparable in two groups and there was no significant difference observed in adverse effects between the two groups. Now, based on the previous findings, we wanted to compute a formula where we could predict the first year growth velocity response to growth hormone. We evaluated both prepubertal children and the peripubertal children and tried to identify the positive predictive variables. So, for prepubertal children, we found that the difference in midparental height SDS and the height SDS, as well as the younger age at baseline, were the positive predictive variables. And for peripubertal, for the mother's height, female gender, and the difference between the midparental height SDS and the height SDS were again positive predictive variables, which we put in the formula to compute the prediction for the first year growth velocity in response to growth hormone. Now, what will be the predictors of growth hormone response? It will depend upon the etiological factors, the pre-treatment factors, and the patient whether he is on treatment or not. So, depending on the etiology of the short stature, whether it is associated with any growth hormone receptor polymorphism, for example, if the patient has growth hormone resistance, it is very unlikely to respond to therapy. Any pre-existing comorbidities like celiac disease. Now, the pre-treatment variables like the younger age at start of treatment, lower IGF-1 at baseline, the greater bone age delay, the greater severity of short stature again makes it more favorable to respond to therapy. Again, when the patient is compliant to treatment in the first year height gain, are again the positive predictor response to growth hormone. So the most important predictor will be compliance to treatment, and the best long-term predictor of height is the height gain in first year. I will now like to call upon Professor Khandelwal to carry the presentation forward.
So when we were working through these growth hormone cases, doing growth hormone stimulation test was really difficult. You have to take 5 or 6 times blood. So we thought, can we use any other alternative? Can we study? So we decided to study the serum metabolomics. Can we use in diseases with the growth hormone deficiency as well as excess of that? We collaborated with National Drug Testing Laboratory, NADA. NADA has a World Anti-Doping Agency approved laboratory under Ministry of Sports and Youth Affairs. And this was our project funded by Indian Council of Medical Research. And I would request our postdoc, Dr. Nupur, to come and give details of this work, which was collaborated with NADA.
Thank you, Professor Khadgawar. Yeah, altered expression of growth hormone leads to growth hormone deficiency and excess, but both these disease states poses diagnostic challenges as the growth hormone secretion occurs in pulsatile manner and its secretion is also influenced by various factors. To mitigate these problems, we did serum metabolomic analysis, which deals with the study of small molecules lesser than 1500 Dalton. The objectives of the study were to investigate changes in metabolic fingerprinting associated with perturbed GH levels, to identify biomarkers and related metabolic pathways using LC-based metabolomic analysis, and to study how patients undergoing replacement therapy affects body's metabolism and identify potential biomarker associated with different GH statuses. The sample group consisted of 40 GHD subjects were compared with 40 age and sex match healthy children to have a deeper understanding of how growth hormone replacement therapy affects body's metabolism. We did longitudinal metabolomic analysis, and for it we collected samples from subjects who were on 20 subjects who were on GHRT at 3 different time points: baseline, 3 months, and 6 months after the start of therapy. Samples were also collected from 75 subjects who were on GHRT for more than 6 months, and from 30 subjects who stopped GHRT more than a year ago. The next group was growth hormone nexus. For it, we collected samples from 50 acro patients and compared it with 50 age and sex match healthy adults. For analysis, high resolution Orbitrap mass spectrometer was used in full scan positive polarity mode, and all statistical analysis such as principal component analysis, principal least square discriminant analysis, heat map, volcano plot, etc. was done using compound discoverer software from Thermo, and pathway analysis was done using free web tool MetaboAnalyst. Now coming to the result of metabolomic analysis between GHD and NCC, PLSDA, which helps in identification of differential metabolites, was applied, and top 20 metabolites from this analysis is shown in heat map. Is shown in heat map, and using these metabolites we did PC analysis and obtained clear separation between the two groups. Next was longitudinal analysis, and for this we did pairwise comparisons between GHRT3 and GHRT baseline, GHRT6 and GHRT3, and GHRT6 and GHRT baseline. And we observed that administration of therapy resulted in shifting of metabolomic profile towards NCC, and most profound changes were observed in GHRT6, as can be seen in the heat map. More than 5-fold change in the level of metabolites was observed in GHRT6 patients, GHRT6 subjects as compared to baseline. Next, coming to metabolomic analysis between subjects who were on GHRT for more than 6 months and NCC, and as can be clearly seen, not much difference is seen in the metabolomic profile of these two subjects, suggesting that GHRT is able to mitigate metabolomic alterations associated with GHD. Next was, we also did metabolomic analysis for GHRT of subjects with NCC, and we observed that the effect of GHRT was reversible, as can be seen in the heat map. More than 10-fold change in the level of metabolites was observed in GHRT as compared to NCC. Now moving to analysis between GHE and NCC, more than 232 significantly perturbed metabolites was observed in GHE group, and the top 20 metabolites from PLSD analysis is shown in the heat map, and the most significantly perturbed metabolic pathways were associated with lipid metabolism, such as linolenic, amino acid metabolic pathways, etc. Coming to the conclusion, significant metabolic perturbations were observed both in growth hormone deficient and excess, and GHRT was able to mitigate metabolic changes associated with GHD, though if these changes were reversible as evidenced in the heat map of GHRT off and NCC, and the significant perturbed metabolic pathways were found to be associated with maintenance of membrane structure, amino acid metabolism, protein turnover, energy metabolic pathways, etc. Thank you. Now I would like to call upon Professor Khadgawat to move forward with the presentation.
So this is still manuscripted under preparation, and we are likely to submit by the end of this month. I would request Dr. Iram. Dr. Iram is assistant professor with us to carry forward with our experience with a few other conditions than the growth hormone deficiency.
Thank you, sir. So I will be talking about some special group which we have experience of 24 stages. Turner syndrome, which is a phenotypic females with complete or partial absence of other X chromosome. They have two main cardinal manifestations, which are hypogonadism and the short stature. So currently we have around 135 patients of Turner syndrome. Among them, in 40 patients, we have already started growth hormone. And among them, in 22 patients, we have completed at least 1 year of growth hormone therapy. The mean age of starting growth hormone in these patients was 13 years, with a mean height SDS at the starting of treatment was minus 3.2 SDS. And after 1 year of treatment with growth hormone, the mean change in height was around 5 centimeter after 1 year, and delta height at SDS was 0.26. Coming to the another special group of short stature, which is very rare causes,
is a Lamb syndrome or the growth hormone insensitivity, which is mainly the defect in the growth hormone receptor or downstream signaling pathway. They usually present and mimic like a growth hormone deficiency with a normal birth weight and length, but they are severely short of height standard deviation of -4 to -10 SDs. And the only treatment for them is the recombinant human IGF-1. They will not respond with the growth hormone treatment. So currently we have around 9 patients with a Lamb syndrome, and they all have very low height SDs, even up to -7 SDs, and all have high peak GH level with a low IGF-1 level. This is our experience of treating Lamb syndrome with the recombinant human IGF-1, which it is not marketed in India, and we have imported IGF-1 after taking special permission from DCGI. This is a girl, she is 13-year-old with height of only 100 centimeter, which is the height of around 4-year-old child, with an SGS of -7.8. And we have given IGF-1 to this girl on which she responded with a height velocity of around 6.5 centimeter in first year and 5.5 centimeter in the second year. And also we started in 3 to 4 other patients which are in the follow-up. Coming to the other special group, which are pediatric lateral cell histiocytosis. So we did a retrospective analysis to look for the growth failure in these subgroups. We have around 62 patients, and we divided them in 3 subgroups with multifocal bone disease, soft tissue involvement, without organ dysfunction, and with organ dysfunction. And we found that almost 44% of these patients have the growth failure, and 19% has cerebral DI. And after giving the treatment for the lateral cell histiocytosis, there was significant catch-up growth. But those subjects who had cerebral DI, they did not show the catch-up growth. So it's very important to look for the complete endocrine hormonal workup in these patients, and also to look for the DI during initial workup and follow-up so as to treat accordingly. Now I would like to invite Dr. Sachin to present data from our department.
Thank you, ma'am. I would like to present data from our pediatric and adolescent endocrine clinic, which we run every Monday from 2 to 5 p.m., where we have a cohort of 315 patients who came to us with short stature. And then we saw that their baseline mean height was 121 centimeter, and with a height gain of around 7 centimeter in the first year and around 10 centimeters by the end of 2 years. The final height which was attained, mean final height attained was 138 centimeter, with a significant difference between the males and females who received the growth hormone. And the mean final height among the males who received growth hormone was 144 centimeters as compared to only 132 centimeters in those who did not receive GH. And the final height in females who received GH was 138 centimeters as compared to only 124 centimeters in those who did not receive GH. So coming to gender-based distribution of the data, so in the males, as we can clearly see from the graph, there was a significant improvement in the height SDS with the progression with a year of GH therapy as compared to those who did not receive GH, where we can see that their height SDS actually faltered with, especially in the first year. And a similar trend was also seen in females, where the height SDS faltered with no receiving of growth hormone therapy as compared to those who received growth hormone therapy. There was a significant improvement in the height SDS with time. Coming to the etiology of growth hormone deficiency in these children in our OPD, in 315 individuals who had growth hormone deficiency, the majority of them had isolated growth hormone deficiency, 263 of them, and 52 of them at the initiation of treatment had multiple pituitary hormone deficiency. After starting GH therapy, 75 individuals had multiple pituitary hormone deficiency. Among the individual hormone deficiencies, the most common deficiency was that of thyroid deficiency, with 33 individuals having a pre-growth hormone hypothyroidism, and the second most common was the hypocortisolism. After starting treatment, 19 additional individuals had hypothyroidism, and 8 additional individuals developed hypocortisolism after initiation of growth hormone therapy. We had imaging parameters in 187 of the 315 patients. The most common abnormality seen in the MRI was the anterior pituitary hypoplasia, seen in around 63 individuals, and pituitary stalk interruption was seen in 10 individuals with the short stature, and ectopic posterior pituitary was seen in 8 individuals. Of the total 315 participants, 206 of them were prepubertal, and we gave growth hormone to 204 patients. So after talking in detail about the short stature, so coming to the other end of the spectrum, tall stature. So is there any concern for the family in tall stature? So what is tall stature? Tall stature is defined as height of 2 standard deviation above the corresponding mean height for age and sex as observed in the population, that is above the 97th centile. However, it is much more acceptable in the society as compared to short stature. That is why the reference we get in the OPD is less. The most common cause of tall stature is familial tall stature, that is defined as height SDS, which is within 2 standard deviation of the mid-parental height. So we have the only series in the country on the profile of tall stature, which was published in 2020 in Indian Journal of Endocrinology. So we have published a series of 16 subjects who presented to us with tall stature, who had a mean height of 173 centimeter, and we did a detailed workup of each of these patients, and we saw that 3 of them had acrogigantism due to pituitary growth hormone excess, and they subsequently underwent surgery for the same. And we had 1 individual with Marfan syndrome and 2 individuals who had exogenous obesity, which was causing the tall stature. And now I'd like to call upon Firdaus for final.
So even just to summarize, we started working on pediatric and adolescent endocrinology clinic since 2000, and now we have around 6,000 patients in our regular follow-up. It runs once a week, Monday afternoon, and referral we are not only getting from the different part of the country, but we are getting from the neighboring countries. Nowadays, we are not getting from the Pakistan because government is not providing visa. Otherwise, previously used to get patients from there also. We provide growth hormone free to all patients for 2 years with the help of CSR funding. We are trying to get more CSR funds so we can provide them for a period till their fusion of epiphysis. And recently we have added another area to our pediatric and adolescent clinic is transgender clinic. So 2 to 5 we run pediatric endocrine clinic, and from 5 to 6 or 5 to 7 we run transgender clinic, and we have around a cohort of 450 patients. And all this during workup since 2008, we have total 200 and total 72 publications, 5 best paper award, and 1 AIIMS Excellence Research Award shows that our hard work in that. And this is to acknowledge all those people who have contributed in the journey of that, starting from Dr. Arundhati from Department of Anatomy, Dr. Deva from Department of Radiology, Dr. Alpesh did DM with us for a brief instant. He was assistant professor and now finally is associate professor at AIIMS Bhopal. Dr. Rahul is also assistant professor at AIIMS Bhopal. We have Dr. Ashima, she is professor of pediatrics in Molnajad Medical College. Dr. Arun is working in corporate sector. Dr. Shweta, who did our genetic work, now she is shifted and based in UK. And this is our staff, Shweta, Dr. Rekha, Vanshja, Monita, Sapna, Ajay, and this is our lab staff, all who worked with us during and provided support to our growth clinic. And in the last, living with a very unfortunate but strange picture. This boy, 8 years old boy, with 95 centimeter, and 95 centimeter height is almost 2.5 to 3 years, with severe IGF-1 deficiency, what we call as Laron syndrome. So there is absolutely undetectable IGF-1 level. And this is when this boy was admitted with us when we were starting IGF-1 therapy. At the same time, we have another patient admitted, 48 years old, acrogigantism, and with severe IGF-1 excess. On one side, there is severe IGF-1 excess, and this side, severe IGF-1 deficiency. So this is a spectrum of our growth disorders, severe short stature to tall stature. So this is all from our side. If there are any question, would be happy to answer. We have just finished in time. 1 minute is left. Sir,
This is the beauty of our specialty, that we have treatment for whatever we treat. We have the treatment for almost every disorder. Thyroid disorder, we give Altroxin, and that too cheaply you can treat the patient at virtually no cost. We have diabetes where we give insulin and we treat the patient and they survive. We have Addison disease, steroids are there, and in premature ovarian insufficiency also we have. So we have treatment for almost every disorder. With Dr. Khadgawat, actually I was just about to say Dr. Growth. So, Dr. Khadgawat, he has shown beautifully how we can treat patient with growth hormone deficient child. And the most important aspect which I find in Dr. Khadgawat's presentation is not only the new information which he has given, growth hormone is one of the costliest therapy, unlike thyroxine and insulin and other. And he has been single-handedly managed to get the growth hormone for so many patients. It's really remarkable achievement. And I wish him all the good luck and more publications. And
sir, Kannan sir. So last concluding remarks.
And actually, you have nothing to treat this patient. That is the challenge. And then also looking for what surgeons can do.
Surgeons can do, sir, a lot. Surgeons can do a lot, but neurosurgeons. So yes, transgender can be done. Sir, we have large number of patients. If you are ready to do, we will send.
We will reassign. There is no problem. So again, I'd like to echo the sentiments expressed by some others. It's, you know, it was very, I know it's what Dr. Goswami said, but at one stage it was very frustrating that you know you can treat, but you cannot for want of financial implications. And I think the effort put in to arrange the funds has been quite spectacular. It's 2 years of therapy will make a difference to a lot of people's physical life, and I think also sort of mental and social life in that sense. So that's really important. I think that the issue, however, is that more people should be recognized early enough to get the benefit. We still get people who are growth hormone deficient who come very late in the course of their disease, and then the incremental gain of giving that growth hormone is not as spectacular as one would have hoped. But clearly, I mean, things are looking up, and we hope that this can increase in leaps and bounds. Of course, collaboration, cooperation from multiple sources have made this possible. So, stop here.
So we try to give them growth hormone for long. So by giving growth hormone for 2 years, at least we will make them able so they can climb to chair, they can open door, they can sit chair, they can work on computer. On an average, what we have seen, if isolated growth hormone deficiency, they have gained 12 to 15 centimeters or more in their first 2 years. Even once we stop growth hormone, it's not that they will stop growing. They will be growing, but growth hormone velocity would be like 2 centimeters or 3 centimeters a year. And finally, they will remain short or 20 to 30 centimeters from their mid-parental height. We wish we could give them more. We are trying hard to pursue different sources. They can provide more CSR, so we can provide them growth hormone for longer duration. But anybody who is coming, we are providing growth hormone for 2 years. Any questions? Thank you very much for your patience for hearing.